Necitide is one such drug which has shown some promise. Urinary alkalization, either it works by helping us clear the hemoglobin or helping us by reducing the sodium chloride. We really don't know, but they seem to help us. And lastly, before I close, just for thought, a high cutoff renal replacement therapy which have been primarily designed to remove myoglobin during rhabdomyolysis. But then, if you can recollect, myoglobin hemoglobin molecular size is almost the same, and they can also be very good in removing hemoglobin that is released. No trials have been so far done, so that would be an area of research. And ischemic preconditioning also have shown some promise in preventing acute kidney injury post cardiac surgery. Statins have no effect on acute kidney injury, but they have shown some effect in retarding the inflammation. So, AKE is common in cardiac surgery patients. So, better understanding of biomarkers, new ideas about pathophysiology and prevention treatment are currently available. So, this is an attractive domain for intervention trials, and trial designs have to target high-risk patients to improve the power of detection. Thank you.
Thank you, Dr. So, how many days before planned bypass surgery?
It is recommended that we stop at least 24 hours prior, because it prevents the body from having one preventive method, that is, it directly keeps the.
Going by the concept that generally a drug needs to be stopped at least 5 doses before it leaks out from the body. So it would be better to stop it about 300 before.
Yeah, that the leave is 1 day, and if you can stop it more than that, better.
Thank you. The case is open for the questions.
You said about erythropoietin as a renal protective. You mean that patients with CKD going for all patients going for
This is in all patients they got there.
how is it against the
They say it changes the inflammation in the body. Because these people suffer from inflammation. They have a very high inflammatory markers post surgery, and also with an element of to some extent they also measures like something like ischemic preconditioning. So for all these reasons, people have tried 20,000 to 40,000 units, so single dose post surgery.
Any questions, comments? Yes, this is a question.
I have noticed is a single surgeries that were done result in a altogether different percentage of acute kidney injuries rather than a pool of data. So in an institute, it's very difficult to find a cardiothoracic surgeon who would agree to be included alone for acute kidney injury. But luckily when we did study, our cardiothoracic surgeon has agreed to be included as the lone person whose data is to be analyzed. And subsequently we have analyzed the pool data of the entire unit. There is a lot of difference. So, in fact, when I went through the literature, very few papers, individual surgeons operated acute kidney injury versus a pool data from a unit. So, what I would request the youngsters to go with is definitely the dexterity and skill of the surgeon plays a very significant role in the outcome of these inserts. So, we have to select if there is a possibility regarding these things. And the second aspect is probably for the sake of younger colleagues, lot of work has been published in Indian journals by our own people who have done in India. So I would request the speakers to kindly review our Indian data also, because that is probably more relevant to our people than what's happened in England and US.
Absolutely.
I request Dr. Dinakaran to present a memento to Dr. Muthu Jayaraman and Dr. D.K. Saha. Dr. Dinakaran. Thank you, sir. Thank you, ma'am. Thank you, sir. Thank you, everyone.
The reason for telling is nearly 6 to 4 crores of people may be suffering with CKD at the the same time our economic resources is very much limited. That reinforces the need of early diagnosis and prevention about CKD. So the prevalence of chronic kidney disease MBD. In first line, that's all depends on the what is the definition of CKD MBD. So it is commonly calcium abnormal. So that's all depends on calcium less than the reference rate, phosphorus more than the reference rate, and IPTH more than the reference rate. The x-axis shows the GFR level and is the percentage of the patient having the CKD. When GFR is 80, the IPTH clearly 25% of the CKD patients have the MBD, mineral bone disease. When GFR is less than 20, nearly 85% of the CKD patients have CKD MBD. So it is almost 85% means it is very high number. The second slide is very interesting slide. The red line is FGF23, even though it is not included by the KD group. It is the earliest marker that rises, followed by PTH. Both is reaches the peak level when the patient is on dialysis and persists remains for a very longer duration even with the working therapy. So this is the PTH, is the phosphorus hormone. Sorry, it is phosphorus, serum phosphorus is maintained till the GFR is 30, and after 30 GFR compensates the mechanism phase and phosphorus increases. CKD Indian registry, there is percentages are not given, but it is very clearly shown that the CKD stage progresses, serum creatinine, serum calcium values are coming down, phosphorus values are increasing, and IPTH values are increasing. This is CKD Indian registry 2011. So coming to history is the history of the CKD MBD. First time the association of the calcification of arteries with hydronephrosis was described a century ago by Brion et al. And in 1921, the bone deformities in chronic nephritis was described. In 1943, calcium abnormalities in renal failure was described. In 1966, calcium phosphorus association with the CKD arrhythmic patient and CKD MBD patient was described. In 1970, the vitamin D deficiency was differentiated from renal deficiency. In 1987, that is 25 years ago, nomenclature of ASBR, American Society of Bone Mineral Research, was defined. Bone histomorphometry, that is how to read the, just like renal biopsy, how to read the bone biopsy. It was described by 25 years back, but even then the availability of bone biopsy reading is very difficult and it is not readily available everywhere. And in 1997, a very good study that is Clarko was described by Kuro et al. In 1997. In 2000, the FGF fibroblast growth factor was described in 2000. It was initially described not in CKD patients. It was described first in hypophosphatemia, autosomal dominant hypophosphatemia patient. When they evaluated for the phosphatory hormone, they discovered FGF. Later, the role of FGF in CKD was very much described. In the year 2000, the histomorphometric measurements were described. So, coming to the definition, earlier definition was renal osteodystrophy. That means it is an alteration of bone morphology in patients with CKD, and it is one measure of the skeletal component of the systemic disorder. That is quantifiable by histomorphometry of bone biopsy. That means to document the CKD MBD, earlier renal osteodystrophy biopsy was required. Now, in 2006, KDO question statement, the diagnosis was very much expanded and it is more practical because bone biopsy is not readily available. They included the lab parameter that is commonly come across by anybody can do, and beyond the bone they added the vascular complications. So abnormalities of calcium, phosphorus, PTH, vitamin D metabolism was included. FGF23 was not included, and abnormalities of bone, vascular, other soft tissue calcification. included. Is the diagrammatic representation of the definition of CKD MBD. So here lab abnormalities include increased PTH, phosphorus and FGF protein, decreased calcium level, calcium and abnormal BMP, decreased BMP and calcification. And the reason for thinking of CKD MPD about thinking as Dr. Professor Devkumar sir already said about it is high prevalence of CKD MPD, and it is not only the bone symptom, it involves the CKD fractures, water, heart, fractures, calcification. So regarding guidelines, think global and act local is the latest statement. In year 2003, KWD published the first time guidelines on the bone metabolism and disease in CKD. In year 2009, KDO CKD MBD guidelines were published. Later, the guidelines were again commented or reinforced in every country in national bodies are endorsing the KDO guidelines. The reason is not to comment the KDO guidelines. The international guidelines may not be applicable to local people. So that like Indian Society of Nephrology developed guidelines of commentary on the KDO in year 2011. It included the few changes in the KDO guidelines and applicable to Indian patients, and based on finance they added few points. The classification, traditional classification and old classification based on these three parameters. One is the area of fibrosis. Second one is area of osteoid. Third one is bone formation. Based on this one, mild osteoitis fibrosa, mixed osteomalacia, the classification was done. Next, spectrum of renal osteodystrophy. In low turnover on one side and high turnover on another side. PTH and calcium move in opposite direction. In low turnover disease, calcium levels are high. In high turnover disease, opposite occurs. If the low turnover means adenic and osteomalacia, high turnover means osteoitis fibrosa. This is mixed lesions. This is the new classification published by the KDO guidelines. The TMP classification, very good classification. It shows the three axes. In this axis, turnover was described. In this axis, mineralization. This axis, bone volume was described. OM means osteomalacia. This is low turnover and abnormal mineralization. Because of the abnormal mineralization, osteoid formation will be very high. The adenic bone disease is also low turnover disease, but the mineralization is normal in adenic bone disease. In osteoitis fibrosa, the turnover is very high and bone volume is high, very high, but mineralization is normal. This is the new classification. This is the how a pathologist treats the bone biopsy, like renal pathologist treats the glomerular lesions and SLE classification, so many things. The pathologist treats based on the four structural, static formation, dynamic formation and resorption. And in each reading, they read many parameters, and by using the so many formulas, they come to diagnosis. It is very well described in this reference. One can go to the reference. So, what is the type of bone disease changes? Before 1995, adenic bone disease incidence was less. Now, adenic bone disease incidence has increased. And in children also, even the most common region is osteoitis fibrosa, 16% people have adenic bone disease. So, this prevalence classification has the highest percentage of adenic bone disease when compared to CKD patient and hemodialysis patients. distortion of fibrosis occurs, even though bone volume increases, it is disorganized bone, no strength. Bone is very big. In adenic bone disease, PTH is oversuppressed, no increase of arterial formation, risk factors are diabetes, paternal diabetes, elderly, excess use of calcium and phosphate inhibitors. In osteomalacia, as I have already told, arterial volume is increases, but it is unmineralized bone. And mineralization lag is very much prolonged from normal from 35 days to 100 days. It is commonly associated with aluminum toxicity. Mixed uremic dystrophy, osteodystrophy means both high features of high turnover bone disease and low turnover bone disease are present. And two more entities are there, dialysis related amyloidosis and osteoporosis. But those two entities are present in the CKD patient, but they are not classified as the CKD MPD. The pathophysiology is whenever the nephron number decreases, the phosphate excretion decreases, so resulting in increased phosphate serum. Increase in serum phosphate. So serum phosphate stimulates both PTH and FGF23. Both increase the phosphate excretion, but when PTH hormone suppresses these old lines is activated and daughter lines is suppressed. PTH hormone stimulates the 1-alpha hydroxylase activity, increase the calcitriol, whereas FGF23 inhibits the 1-alpha hydroxylase, decrease the calcitriol. What is the clinical implication? Both are phosphate hormones, both increase the phosphate excretion. PTH, low calcium and high phosphorus, PTH action predominant. High calcium and high phosphorus, FGF23 action predominant. So CKD phosphorus. What is the, I don't want to discuss how phosphorus is observed in the intestine and how phosphorus is excreted in the tubules. I want to concentrate mainly on the changes in the CKD. So phosphate homeostasis control is maintained till GFR is 60. When GFR reduces less than 60, homeostasis is altered. Between 60 to 30, GFR is big. GFR, serum phosphate levels are being maintained within the normal limit at the expense of increase of FGF23 and increase in PTH level that results in damage to the other organs. That is called trade-off hypothesis. If GFR is less than 30 ml, compensating mechanisms are overwhelmed, hyperphosphatemia, resulting in inhibition of calcitriol, increase of PTH, secondary hyperparathyroidism, and tertiary hyperparathyroidism. This is FGF23. Why 23 means already there were 22 superfamilies are present in the fibroblast growth factor. As it is 23rd, they find as 23. It is oxidative hormone means it is increases the phosphate excretion. This is seconded by the osteocytes and osteoblasts. The importance is earlier people thought that osteocytes are only inactive molecules that gives the strength to the bone. Now the latest literature shows that osteocytes is like endocrine cells. Osteocyte, bone, kidney, endocrine axis is very well established, and osteocytes have multiple functions, and it acts as endocrine cells, and it affects the FGF23. And FGF23 elevation precedes the PTH elevation. Why this is very important means earlier whether PTH increased first or FGF23 increased first, there was a lot of controversy whether egg or chick or hen, which is first. But when they did experimental mouse model, when they created CKD model, FGF23 increased, they observed increase of FGF23 at the day 10. So now it is undoubtedly shown that FGF23 elevates first. Why it elevates? Because of the decrease of clearance and because of increase of production nearly 1000 times when compared with the healthy people. Earlier, the increase of FGF23 was mainly due to proper deficiencies. That is, the secondary increase was the primary populations are the kidney injury is earliest illness for FGF23. That is the primary abnormality which is the releasing from the kidney. So initially it maintained, but as the nephron number decreases and as the clot of levels are decreased, FGF fraction drops and PTH levels increase. So FGF23 in human physiology, how it acts? The PTH plasma, D3, leptin, phosphate, cadmium may have stimulatory effects on the FGF23. DMP1 effects or the other phosphatase hormones have negative effect on the FGF23. It acts on the mainly in the proximal tubule and decrease the expression of NP2, sodium phosphate transporter 2, and decrease the 1-alpha hydroxylase and decrease hyperphosphatemia. In parathyroid gland, FGF unique feature is it suppresses both the phosphatase hormones, but FGF inhibits the PTH hormone. But PTH has some escaping tendencies. I will show it in next slide. So it is very important slide, and a lot of reviews has published on this one. Is the FGF23 is the biomarker or it exerts toxicity over the other organs, like NGAL in the acute kidney injury. It is a simple biomarker, but many studies have conflicting results. Few studies have most goes in favor of biomarker and few studies have in favor of toxicity. What toxicity it can produce means FGF levels is predictor of PKD progression and higher levels are associated with mortality, predictor of fracture disk, and it is associated with vascular dysfunction. There are many studies are there. And if it is toxic, what is the benefit here? So if it is by reducing the FGF23, is it beneficial? How to reduce FGF23? By giving chinacalcides, antibodies. They develop antibodies towards the FGF23 and they reduce FGF23. So based on this one, is there any new clinical use? But the problem is whenever they reduce the FGF level 23, phosphate levels goes up. So that whenever in CKD patient, the treatment is very difficult. In patient is on hemodialysis, the phosphate is removed through the dialysis. These treatments are newer therapeutic regimens can be tried. The clotho, the meaning of when they described clotho originally, they thought that it is an anti-aging molecule. Clotho means it is a Greek goddess. The 3 Greek goddesses maintained during the pregnancy. The clotho goddess maintains the pink thread of life. That's why they coined the clotho. But initially they thought that it has more role in the anti-aging. But now they discovered it has more role in the CKD MPD. So gene expression predominantly in digital convoluted tissues, renal expression decline in CKD. So FGF molecule binds to the clotho molecule and action occurs. In clotho also